Well, thank you, Marlene, and let me extend my welcome to all of you to Charleston as well. What we're going to do over the next 45 minutes is going to be really in three parts. We are aware we have to give the Alpha-1 101 lecture. That's what do the big words mean, what's this disease all about, and talk a little bit about liver and lung disease in a general sense. We're then going to talk about some of the new things coming. Everybody wants to know what's new and what the research is heading to be. And the third thing we're going to do is take a few questions and answers just within this period. I'm going to give up 5 minutes of my time at the end to let one of my coworkers come up and talk about a new concept called community participatory research, where we actually invite you to be members of the research community as well. So what's Alpha-1? So I'm just going to read a few of the words. Alpha-1 stands for Alpha-1 antitrypsin deficiency. We used to say this is a rare disease, and then rare just means that nobody on earth has ever heard of it, so we're starting to call it an uncommon disease. And it is based in our genetics. I'm aware on today's program that our genetics talk is actually the last one of the day. That's our genetic counselor, Dawn McGee, coming up and talking about the genes and how they flow through the family, a very important part of this disease. And I think the most important, there are a few things I want everybody to come out of learning today, one of which is make sure you know your Alpha-1 letters. And the great majority of people with advanced lung disease have 2 copies of this Z gene, and when one of those Z genes goes to another family member, then we designate, because we don't have another great word for it, a carrier state. But we'll get more into the genetics later, and so most people should know that they are ZZ, or the common gene in the population that makes up 95% of the population is the M gene. M from mom, M from dad gives those 95% of people an MM genotype. And so 1 copy of the Z, carrier, 2 Zs, severely deficient. We have a whole story around the S gene, but we'll get into this later on in the day, and I'll be happy to take questions about genetics at any part in this. But my topic's really lung disease for this 45 minutes. The deficiency that those genes give us is a low level in the bloodstream of this chemical called alpha-1 antitrypsin. In our bloodstream, all of us have lots of chemicals floating around. If you try and figure out how many chemicals are in the bloodstream in any 1 minute, it's about 2,500 different proteins going around in our blood. And the number one most abundant of those is a chemical some of you may have heard of called albumin. The plasma fractionators out there, when they get a plasma donor, suck off all the albumin. We use that at the hospital. But a lot of people don't know the number 2 most prevalent protein in our bloodstream is this chemical called alpha-1 antitrypsin. And it is a very prevalent protein going through our bloodstream to help buffer down the inflammation in our body. And so if you're genetically deficient and can't turn off inflammation in our body very well, then what happens is that inflammation goes rampant and can destroy the lungs. When it hurts the lungs, it usually causes a disease called chronic obstructive pulmonary disease. And about 10 years ago, you say COPD, and get my pointer working. And Genevieve, you want to come work on the pointer? Yeah, so my pointer is defunct, and I may have another. I can use my arrow up here for this. And COPD means that we have lung disease of many different varieties, and the varieties of COPD we'll talk about, but generally include long-standing asthma, a disease called chronic bronchitis, where we have inflammation in our airways, and a disease called emphysema. Emphysema is a word that we use to say that there are holes in the lungs. And it's kind of funny when people say, oh, my doctor said I had emphysema. Everybody goes, oh, my. When you say, oh, you've got COPD, you say, huh, what's that? And they're really all part of the same disease. And so this word COPD you actually see on TV a lot these days. All the drug companies out there have tried to figure out that there are a lot of patients with COPD out there. We think there are about 30 million patients in America that have COPD. And we do think that every one of them needs one test in a lifetime for Alpha-1 to figure out who those individuals are that have this uncommon genetic disease. The disease starts in the liver. We're going to spend after the break a fair amount talking about the liver disease, but this genetic deficiency doesn't let the protein made in the liver get out of the liver, and so the liver gets packed up with this protein that's handled well by some people and not so well by others. But if we get deficiency that's going through our bloodstream of this alpha-1 protein, and particularly if we start smoking cigarettes, we get holes in the lungs. And if you look at this chest x-ray, the head's up here, these are the shoulders out on the sides, but the black part of an x-ray are the lungs. When we take an x-ray beam through our chest, what happens is that air inside the lungs is black. It doesn't pick up any x-ray beams. And so the blacker your lungs are on a chest x-ray, the more emphysema is there. The problem is that when you get an x-ray that has lots of blackness on it, like this one here, particularly at the bases, our lung function is really, really bad. So we see that at about 30% of predicted lung function. Don't we want to make the diagnosis when our lung function is just beginning to get abnormal? Absolutely. So the chest x-ray is not a very good way to pick up COPD. Instead, you've got a whole section today on what the pulmonary function laboratory does. And we're going to be talking about pulmonary function tests and FEV1 and knowing your numbers around that as well. The other test we're going to talk about a fair amount today is the chest CT scan. In a CT scan, you go through the big donut and they go zip and they zip you through, and it takes lots of x-ray beams of your lungs. And then the computer reconstructs your lungs so we can see them just like we were cutting you open in little slices and lay out your lungs for us to see. And from the back of the room, you might not be able to see, but there's some little tiny holes in this CT scan that are the holes of emphysema that we can see on CT scans that we sometimes can't see on chest x-rays. So let's kind of get the concept here of why we think clean air is important for patients with alpha-1. And so in the normal situation, our anti-neutrophil elastase protection is a big doctor's word, and all that means is that about 98% of this in someone's lung comes from alpha-1 antitrypsin. So in the normal situation, we make boatloads of alpha-1 protein, and this chemical called neutrophil elastase is a chemical that comes out of neutrophils. Neutrophils are one of our white blood cells that help fight infections in our body. And what happens with neutrophils in the lungs is that they've got this little chemical that they use to kill germs called neutrophil elastase. If you give enough neutrophil elastase, it also hurts the lung, though. And so when we smoke cigarettes, for instance, we get lots of extra neutrophil elastase put into the lungs. And in the situation where now you don't have very much alpha-1 around, what happens is the lungs get destroyed. We tip this balance towards lung destruction rather than keeping your lungs good and healthy with lots of alpha-1 bathing the lungs and keeping them from getting infections and from getting neutrophil elastase injury. So lung damage is a result of both extra neutrophil elastase and lack of sufficient alpha-1. So what does that mean? Well, if you get enough augmentation therapy and you pop that alpha-1 level up, can you still keep smoking? No. We need to fight just as much that neutrophil elastase burden, so we don't want any neutrophils in your lungs. Obviously, you have to have some because we have to fight infections and other things that happen as well. But it means when we get an infection, we want to treat it very rapidly. If we have coughing up yellow and green mucus, bad thing. All that's just where all those neutrophils are living. And the other piece of this is that lots of things bring in neutrophils into our lungs, and these include irritants that we use from cleaning products and working in a dusty job environment. And how far down that ladder we go, does that mean Uncle Joe has to walk in your house naked because he's got some cigarette smoke on his clothes? I don't know, but it's one of these things where you worry about how much clean air you get and just how much of a clean air environment you really want for you and your family. So it's important to have clean air, no infections, and not smoke to lessen your neutrophil elastase burden. All right, so this is, they made it a guy, but it could be a girl. You know, women have more COPD in America than men. Most people didn't know that. So more women died of COPD last year than men did. And what's been shown is that if you go to your family practice doctor with cough and wheeze, and you have pretty good lung function but a little bit of obstruction, about 3/4 of them leave with a diagnosis called asthma. How many people were first misdiagnosed with asthma in the room? Yep, and they're all women, notice. And all the men that come out often get diagnosed with COPD. And so there's this mindset that, oh, men smoking get COPD and women get asthma, and it's just not true. Oh, yeah, go ahead. And so what happens in the lungs here is that we have airways that come down to the air sacs. The air sacs are called alveoli. And emphysema is the process where we break down that little barrier between one air sac and the next one. And so instead of having 10 little small alveoli here in the normal situation, we get now one big alveolus. And so we've got a bigger airspace there. That's a hole in the lung. That's emphysema. We also, as the result of Alpha-1, get some airways disease. And notice right here, this airway is very narrow. That's because some of the elastin, the rubber bands that help hold open our airways, have been lost in this disease called Alpha-1 antitrypsin deficiency, or COPD. So that airway there is real floppy. It collapses when we go, as we exercise climbing a flight of stairs. Those little airways are completely closing off. And what that means is that there's not a medicine that adds back the rubber bands to that airways if we've lost them. And so this is part of that neutrophil elastase damage happening in the airways, the same way the emphysema forms in the lungs. If you think about it, if we take all of these little air sacs and we were to lay them out flat, what we know in our lungs, we have about a tennis court full of airspace. And so now we're starting to chop up all the little air sacs walls in there. And so now when we get emphysema, you start playing half-court tennis, and then a little bit less as our emphysema progresses. We're losing some of those little walls that are rich with blood vessels that help get oxygen into our system. And so this process of emphysema progression will eventually leave us with less oxygen in our body, while we see some people wearing oxygen in the crowd today. Well, so what does it look like in our clinic? This is the slide we showed to lots of doctors' groups. When most people develop their first lung symptoms with this disease is about 35 years old. That's what used to be thought, and I'll show you some of the newer data here in a minute, but this came from Dr. Stoller's assessment of the Alpha-1 association population that had visited the Cleveland Clinic back in 1994. And this is the number of doctors that it took to make the right diagnosis. And so all these people were being misdiagnosed for a long period of time. Do we think that's any better today? Not very much. We think it's a little bit better, but it's hard to prove that we're actually getting all those doctors out there really smart in Alpha-1 as they come out of medical school. We try mighty hard, but this, like the other 7,000 rare and uncommon diseases out there, don't get quite as much attention in medical school as congestive heart failure and diabetes and high blood pressure and all the things, cancer, all the things that happen very suddenly. So we're trying to educate our doctors. And what does that mean? We need y'all to educate your doctors as well. So part of today's agenda is actually getting you smart enough to be able to walk into your doctor's office and say, this is my disease, And you got to learn about it. And so that's why a third of our calls to our genetic counseling center come from medical professionals. If you leave their office, sometimes they just pick up the phone and call us, what's all this stuff about? And that's a good thing. They're learning about you so they can take care of you better. All right, now we mentioned some of these genes. What happens at the gene level, MM being the normal situation, is that we then produce an amount of alpha-1 antitrypsin that can have a different blood level every single day. So we usually measure this level in milligrams per deciliter. There's another measurement scale over here called micromolar, and it gets very complicated. But the point here is that there's no real reason for anybody to be following blood levels on a daily basis, because over here in this MM guy, one day he can have a level down here low in the bar, next day he can have a level up here, and it goes up and down every day. What happens in the ZZ population is it goes up and down, but it doesn't go up and down enough to make the diagnosis not be pretty evident on a blood level. So a lot of doctors will screen on the basis of a blood level, but we really want to know what our two genes are. This is your signature of what kind of alpha-1 that you have. And so we do have individuals that have an S gene hooked up with a Z gene and two Zs. We have about 90 genes that don't make any alpha-1 that are called funny names. So about 5 years ago, when we run out of letters for the genes, because there are 100 of these null and rare genes, we have to name them other things. We name them after the town you were born in of the index case. So 5 years ago, we named Z Savannah off of one of the patients that came to see us, and they went and did the genetic sequence and figured out what this rare null gene was. So there are a whole bunch of these rare genes out there that make variable amounts of alpha-1, but generally they don't make any if it's a null gene. And so just recognize that when somebody says, I'm an Z Maryland or something like that, you just say, okay. Our next topic here is trying to figure out, well, what about this environment piece? And one of the important studies that was done in the past decade was, and many of you in the room participated in it, is where we invited brothers and sisters that had two ZZ brothers and sister pairs, ZZ sibling pairs, to come and visit our... Okay, let's see if it works now. Which one? Guess not. You got it? Okay. Well, we'll find some batteries sooner or later. It's hard out here sometimes. They don't have fire trucks either. That's reassuring, isn't it? So these ZZ sibling pairs came into the to the study. They did breathing tests. They talked about their smoking, and what's pretty evident here, I've put all the non-smokers in red up here and all the smokers in blue. And I think, we've always focused on these individuals that have young age, 30 to 50 years old, with really bad lung function. 100% lung function would be normal. Oh, you got it. Top one? Oh, yeah. Thank you, Genevieve. And so 100% lung function would be normal lung function up here, and bad lung function, 20% predicted down here. Notice there's a guy down here with 10% lung function, so you can live with really, really low lung function. But there's this clustering down here with the smokers. But notice this guy, age 70, smoked 2 packs a day for about 20 years, and he's got 82% lung function. What's up about that? And this guy, non-smoker, age 45, with 38% lung function. What's up with this guy? And so even though we've got the message that smoking is a bad thing in alpha-1, we've got a lot of scatter here in these brothers and sisters. So who's going to come see the doctor? All these guys with low lung function, which is why we say stop smoking, stop smoking, stop smoking. I'm not showing this slide so that y'all can keep smoking up here and keep good lung function, but just recognize that there's got to be something else in this story to try and understand more about Alpha-1, and that's what all of our research is about, because otherwise, if it was just smoking and genes, it'd be a simple thing, but we think there's a big environmental message around inhaled particles and keeping your lungs clean, independent of the whole smoking story. And so this is a very powerful slide. It kind of helps to understand not only what you should come out of here knowing, what's my lung function and how's it going, but also trying to recognize there's some 80-year-old guys out here and girls, which are where we all want to be. So what happens if you don't smoke? Well, one of the best studies that we have out there is this study where they tested every baby born in Sweden from 1972 to 1974. They tested 200,000 babies and found 127 individuals that had 2 Z genes as they were being born. These guys they're about 35 years old now, so this is our very best study of the natural history of what happens with alpha-1 antitrypsin deficiency. What they knew in 1974 was that smoking's bad, so they told all the parents, don't let your baby smoke. And yet, what happened at age 5, the parents were smoking at twice the rate of the normal population because they were so worried about their kids. And so there's a lot of secondhand smoke exposure. And yet the babies actually did a pretty good job. In Sweden, 30% of the population still smokes today. As y'all know, it's falling. It's 19% of the population in the United States now. But when you looked at those individuals that were ever smoking with ZZ up to age 30, it's still 21% of them picked up a cigarette. And it might not be as much smoking, but I still think that's really a bad sign. We'd like that number to be 0 in our kids. But if you look at the rest of the population, 34% of the people born in the same year that had normal genes smoked. And those individuals that did smoke, ever smoke, yes, at age 30 start having phlegm 30% of the time, shortness of breath 65% of the time, and wheezing 48% of the time compared to those that never picked up a cigarette. So what does that mean? Well, if you're really good and keep your babies healthy, well, they still have 13% mucus, 36% shortness of breath, and 26% wheezing at age 30. So this disease is happening, although it's not happening as frequently, just on the basis of our gene, and we really don't know the whole story around secondhand smoke in this situation. We really think secondhand smoke is a pretty powerful measure of what happens eventually to your lung function. So in our lungs, I think we know that there's emphysema. The emphysema tends to happen at the base. We have COPD, and we're going to talk a little bit about another big word that I want everybody to try and remember today. Everybody's heard of bronchitis. Itis means inflammation. Bronch of our airways, our bronchi. But we have this extra little ect in the middle of this, and that ect means you got some dilation. So this is bronchiectasis. Everybody say it together. Bronchiectasis. Very good. And bronchiectasis means that we've got some dilation of our airways that's permanent, and it means that we hold on to a little bit of extra mucus in our airways that makes it harder to get out than simple bronchitis. And so when your doctor doesn't want to give you an antibiotic because he doesn't want to overuse antibiotics, and you say, well, but you know I've got a little touch of bronchiectasis, don't you? He'll say, oh yeah? And then he'll give you your antibiotic right away. So it's a disease, and we'll show you some pictures here in just a minute of what bronchiectasis is. And it's an important word to learn in this big vocabulary of alpha-1 and disease. We're going to talk later about cirrhosis. Cirrhosis is a big doctor's word that just means scar in the liver. We have a disease called vasculitis. Itis, inflammation of blood vessels. So this is a blood vessel inflammation disease. We're not going to talk about it today, but any of you that might have some questions about it, we can ask later. There is a disease called paniculitis, itis, inflammation of our pannus. Our pannus is our fat. So these people get little sore, inflamed areas that move around our body in areas of fat. So necrotizing means dying fat. So you get a little red spot in your fat, and it's on your buttocks or around the fatty parts of your skin. It's actually very rare. Only about 1% of people with alpha-1 will ever have any necrotizing paniculitis. And then I think we have this whole separate agenda of, if you have an individual in a family that has disease, just because you've got the genes doesn't necessarily mean you're going to have the disease. And so we have really two different discussion topics of what to watch for in a family and then how to deal with individual diseases as they come up. Well, this is data that came out of our registry. We're going to talk about the registry later in the day as well. But if you look at our registry population, it really hadn't changed since 2005. Our big peak here is age 50 to 60 and 60 to 70. Our oldest guy out here is 89 years old. He's ZZ. He had a lung volume reduction surgery at the age of 70 and lives in Florida. And the point here is that there are these individuals that just live normal lives with their alpha-1. And so how that works, I think we're not worried that we're still waiting for the first person with ZZ alpha-1 to crack 100. We'll celebrate him. But we think that that's possible in this disease. Marvin. Oh, okay. All right. All right. The other piece that I want you to know about is that we do run this alpha-coded testing study. This is a study where you can do your own test or help your family do their own test in the privacy of your home. It's an online test. We have a lot of information out at our booth outside about how to do this, but you have to go online, electronically sign your consent form, answer a bunch of questions, and those questions are the research that we do trying to understand home genetic testing, which is one of these new and very controversial things because Medicare and Medicaid don't necessarily want to pay to genotype the whole United States, and how you get reimbursed for it and does it add value are the big questions that are sitting out there at CMS in Washington. This is a slide that's about 2 years old. We've up to 16,000 of these. Most of them come back. We make lots of individual diagnoses. Just recognize the MZ individuals. If you're testing inside of a family, there are a lot of people that get one of those Z genes that flow downstream. And so that's 3,800 MZs out there. And part of this study is that we can contact you for the rest of your life if we want to do research with your particular genotype. What that means is if an MZ study were to crack loose right now, we would be able to invite all those 3,800 people to see if you might want to be part of a research study. And yet those studies haven't come forward. But we got your name in our database there. We keep it very confidential so that if we need to do research or want to do research, we'll let you make the decision whether you want to or not. But the other piece here is that's 640 individuals with severely deficient genotypes, the letters of alpha-1 here, including SZ, the Z nulls, and the ZZs, which is actually about 5.7% of the population that tests. When we ask the question, as you're doing your test at home, do you think you're going to be deficient? More than 50% of people say, yes, I think I am. And so that's the thing that's really driving. But the reality is that within an individual family, it's about 5 to 10% of the individuals that actually are severely deficient. We have a lot of carriers of the S and Z gene, MSs, MZs that are out here wherever they are right there. A lot of individuals. Our questionnaires right now are kind of focused on lots of different things. We're looking at secondhand smoke. We're really trying to figure out if there are any other disease besides lung and liver disease that are associated with alpha-1. So we're asking questions about pancreatitis and aortic aneurysms and diabetes and other things that might be hidden in this Alpha-1 story. And so that's part of the research study that's ongoing. We think we're empowering people that we test. We have shown that when you get a deficient gene back, even if it's a carrier, more people stop smoking that were smoking when they came to the test than before. We think it helps families make decisions about occupations. Maybe you want to be a computer geek rather than go work on the road crew where all the dust and dirt flies up and you breathe that stuff in. We think it does give some good genetic data to your family members, and then we can support individuals that need therapy for these diseases. Let's turn now to the research agenda. I think one of the things that's been looming out there for about 10 years now is that possibility, instead of getting our augmentation therapy in the vein, we might be able to breathe it into our lungs or not. So when we ask individuals whether we would rather have inhaled therapy or intravenous therapy, and when you would start such therapy, most people would say, well, it depends a little bit. Some people are just fine saying, yeah, I'll get my therapy once a week in the vein, and some people at double the dose every 2 weeks, which is about a third of the infusion practice in the United States, are happy. Because we think that an inhaled therapy, if it was applied, might be a twice a day nebulizer sitting there for 10 or 15 minutes to get enough Alpha-1 down your lungs to be able to do what it would need to be. And I think that's the burden of these nebulizers. Many of you know them from how much time it takes in a day to kind of clean out your lungs is not insignificant. But when you would get it, I think most people don't want to wait until you get severe lung disease to start any therapy. You'd rather be starting earlier up this pathway. And if you look at the inhaled therapy, a lot of people feel like they would even take it before they got sick. And obviously that depends upon what your lung function is. And so we do think we would be shifting more people into therapy if we had an inhaled drug rather than an intravenous drug. The deal made with the FDA in 1995 was that if we have a medicine like we do that we could inhale, that all the pharmaceutical companies, to get an FDA-approved drug, had to actually prove that it works. And to prove that you can slow the progression of emphysema is about a 3 or 5 year plan. It'd be a very, very expensive trial. And we know in the background is that there are a bunch of these proteins that are made recombinantly. That's a big doctor's word. What it means is that you'd actually put the gene sequence into another animal cell, so like a human cell in a big culture dish or a big vat of these cells, and those cells would pump out Alpha-1. And if you had recombinant Alpha-1, you could just line up the number of vats of these things making these products, and the price would drop really, really lower, we would hope. And so rather than having to get it from a pooled plasma source where you have a lot of plasma donors and they make the Alpha-1 protein after that at a lot of expense, if you could have a recombinant program and get these drugs out cheaper, then we think that all of that would move into inhaled therapy. And so some of those recombinant programs are going on all over the world at a number of different companies. And we think that some of the inhaled trials using the pooled plasma are turning to diseases that they might help in, that they can measure not emphysema progression, but maybe something like how good you can get mucus out of your lungs. And so there's some trials going on right now in Europe for cystic fibrosis, a kid's disease that has bronchiectasis. And so it's another form of bronchiectasis that actually they have good outcome measures and can do trials in about a 6-month time period to show that it might or might not work with an inhaled version. So this is still a long ways away to get through an FDA with an inhaled drug here. We get lots of questions about it. We think it would probably work, but we have to prove it. And it's really a burden that we've been living with for 10 years because we really don't have the studies to show that it works. All right, what's the word? Bronchiectasis. All right, so bronchiectasis, this is a CT scan. And these cool thing about computers when you go through the big donut is we can slice you any way we want to and flip you around and turn you upside down. And so this is a slice right through the side of your body, all the way down through your lungs. So that's the head up here, and there's the shoulders, and a little arthritis in that shoulder or not, I can't tell. And this is the liver down here below your right diaphragm, the muscle that moves up and down and helps you breathe. And so this is the main air tube called the trachea coming down and dividing into the two sides. And these airways as they go out are supposed to be real tapering and smooth. And they're supposed to have very, very thin walls. So when you look at over here, this is the wall of the airway that's about twice as thick as it should be. And we just happen to catch some of these other two airways. This one's kind of tapering down pretty smoothly, but the walls are too thick compared to some of the others. There's one that has real thin normal walls. And what happens to this one? Well, it's got a little bump on it. It actually dilates as it's going out. It's not smooth and tapering. Look at this one down here. It's got like railroad tracks coming down here. That's bronchiectasis. How good do you think your family practice doctor is at picking up bronchiectasis? Not so good. This is a real specialty thing that when we do CT scans of people with Alpha-1, we find bronchiectasis in the largest study in 70 out of 74 people. 92% of people with Alpha-1 have some degree of bronchiectasis on their CT scan. So when your doctor doesn't want to give you an antibiotic, you say, but I have bronchiectasis. And whether you have to get a CT scan or not to prove where yours is, sometimes the bronchiectasis is rather advanced. And that's that source of infection down in your lungs that we really have to work hard, not only to get the mucus out, but also to fight the germs that can live in these little areas of dilation in the airways. It's just hard to get the mucus out from those areas of dilation in our lungs. So that's what bronchiectasis is. It's a dilation of the airways. We think it's anatomic and permanent, but it doesn't mean that we can't do some things to help get the mucus out and fight the infections that can occur in areas of bronchiectasis. So this is if you slice your body through this way as opposed to long ways. This is the edge of the heart up here. And this is one of my patients that had nice thin airways, even though they're a little bit dilated. Notice this makes a little figure 8 right here. One of them is a blood vessel. It has blood in it, and blood is white because the X-ray beam picks up the blood vessel. But this other part of the 8 is the airway. And so now, 2 years later, I'm coughing up lots of mucus, Dr. Strange. What happens? Look at this exact same slice here. That little 8 has big, thick walls to it now, whereas it didn't before. This is this figure 8 piece. The figure 8 is supposed to be equal, or the airway size is supposed to be smaller than the blood vessel. So what happens here is this is a dilated blood vessel that started holding on to infection and has gotten a big, thick airways wall, which is part of bronchiectasis, which is part of Alpha-1, and why this is a burden to get infection in and out of our lungs. One of the interesting studies in bronchiectasis that came out actually came out of Sweden with a particular germ called non-tuberculous mycobacteria. And they took all of their germs that are kind of first cousins to tuberculosis, but they're not infectious, that are called non-tuberculous mycobacteria. And they looked at to see how many people had abnormal cystic fibrosis genes and Alpha-1 genes. And if you just took 100 people on the street, how many people would have abnormal Alpha-1 genes? Well, that's 2 or 3 carriers, and yet there are 15% of their population that have abnormal Alpha-1 genes. There's actually 3 individuals that had abnormal CF and Alpha-1 genes in this population. They were worried that they had thought this through and just had a few patients in their clinic, so they actually did a thing called a validation cohort, a follow-up cohort, and found pretty much the same sets of numbers here, where 12% and 15%, lots of people have extra infections out of Alpha-1. So does that mean that Alpha-1 might help treat infections? Maybe. And therefore, lots of our studies are trying to understand better all the germs that live in our airways. And so the National Institute of Health just last week announced this proposal to study a thing called the microbiome down in the lungs of patients with Alpha-1. They're also doing a disease called sarcoidosis, another one of these uncommon diseases. And what a microbiome is, now we have the genetic sequence of every single germ that can possibly live inside your body. So we can go down into someone's lungs, take a sample of the secretions that are there, and figure out all 90 different germs that live in your airways. And then we're going to end up with trying to figure out if we can treat them in a better way, and understand this microbiome and all the different germs that live there. Last thing I'm going to talk about is this new measure of thing called lung volume reduction. And lung volume reduction means that if your lungs are too big because they have emphysema and trap air, then we want to make our lungs smaller. One of the ways to do that is this little device called a lung coil. And I'll just show you that these are sorts of procedures that have historically been done with surgeries to be able to cut people's lungs and shrink them that way. We have now 4 companies coming to the United States to treat and make our lungs smaller through a scope called the bronchoscope that goes down of our airway and puts these coils out in the lung, and the coils go out straight, and then they retract and they pull in all this emphysema, and they start shrinking the lungs. Some of the other studies, this is a CT scan of someone with really bad holes, lots of blackness up here in the lung, and this side of the lung got squirted a polymer, a chemical that goes out there, and as it dries, it pulls the lung in to be able to shrink that lung. Notice this lung's a whole lot smaller than that one, and now our diaphragm has more curvature, and people can breathe better with these treatments. This particular person improved their FEV1 by 70% from before the lung function test to after the procedure. And so some of these are really dramatic ways to improve lung function that are coming down the pike, and we'll take lots of sorts of studies to prove that they make a difference. All of these are in big practice in Europe right now, so most of them are approved in Europe. They're just not even trialed yet in the United States, and they're coming this way. Any of you that want to travel to Germany and get your bronchoscopic lung volume reduction, we'll give you the address of some friends over there, and we'll talk about it a little bit more during our question and answer session. So we are going to leave for the rest of the day talking about bronchodilators, steroids, antibiotics for exacerbations, augmentation therapy questions, how important exercise is, and transplant. But just recognize that we have a limited amount of time, and I actually talked more than I took questions at this period of time. So I think what I'm going to do is invite 5 minutes for
Sure,
Pam
absolutely.
Williams to come up and talk about our community-based participatory research proposal, because she's going to be sitting outside at the end of the break to talk about this. So you want to come up, Pam?
Oh, great. Well, during the introductions of Dr. Strange, one thing that was left off the list of the wonderful things he does for Alpha-1 is he also stimulates and mentors and shares his passion with other research scientists regarding Alpha-1, and becomes contagious. And then other scientists fall in love with the issues and the passion, and that's what has happened to me. I'm a nurse research scientist at MUSC, and I arrived about 18 months ago and reached out to Dr. Strange because I already was very passionate about the issues in uncommon genetic conditions. Started collaborating with Dr. Strange, and the next thing I know, I'm hooked. So I've spent the last year trying to identify and work with and understand the issues of alpha, looking at the chat rooms. Have y'all ever gone on, show of hands of those of you that have spent time sharing your experiences on the Alpha-1 chat rooms online? If you haven't yet discovered those Alpha-1 chat rooms that are online, they're wonderful places to network with other patients and discuss some of the issues. So anyway, in these short 5 minutes, I wanted to share with you a new research agenda or research initiative that is being born right here in South Carolina at MUSC's backyard. And it is a little different than what you've heard in the last slides about research that's focused on symptoms and symptom management and the genes. Instead, this is a research initiative that is trying to embrace the community and form an alliance partnership to study things that have nothing to do with the symptoms but contribute greatly to the burden of living with Alpha-1. And you all know better than I what those are, but living with Alpha-1 is like being an onion, and you've got your symptoms and your drug problems at the core, but then there's these other layers of problems of living with Alpha-1 that as of yet have not really been adequately researched. Burdens like, well, we've mentioned a couple: the delay in diagnosis, the genetic decisions, the decisions that this condition burdens the family with, the rarity and the hardship in trying to find a provider that knows enough about Alpha-1 that they can adequately manage your condition. These are just layers of psychosocial burden that pile up when you live with Alpha-1 that haven't been adequately researched yet. So this initiative that we've started, Dr. Strange and I have recruited some partners in research, and this is referred to by the social scientists as community-based participatory research. But essentially what it is it's a partnership where patients do more than fundraise and submit for clinical trials. Instead, they sit at the table and help design the research agenda itself. So we started this partnership, and we've had our first inaugural meeting, and I'm going to drop a few names and ask the other partners in this partnership to raise their hands. We've got some really excellent representations so far, but we're here to recruit more, and I want those that are already sharing this partnership with us to raise their hands. We've got Jim Quill has indicated a willingness. Marvin Sineth, everybody knows Marvin. He's in our partnership. Barbara Warner, and Susan Hill. Then in this partnership, we've also recruited some organizational support, and we've got the Registry. The Alpha-1 Registry is represented in this partnership. Mike Graves is here, and he'll be sitting out at the table. I'm sitting with him. We've got Dawn McGee, our genetic counselor. Everybody knows Dawn. There she is. And we just recently have been talking to the Greenwood Genetic Clinical System, and they have indicated some interest to support this research partnership. So this is something that's going on right in your backyard. This morning there was an announcement that we've got 11 states represented in here today. What would be really great is if this partnership could have some representation from other states to join us in our mission. So what are we doing? We are meeting, our plan is to meet by conference, telephone conference, and in person if you're local, once a month. Our earliest agenda has been to start to formulate a menu of some of these problems that you all face in your experience with living with Alpha-1. And we've started a menu that we're going to circulate. As the year progresses, we're going to go to this menu of items of problems that you face, and we're going to prioritize which ones we want to tackle first. So that's kind of a 5-minute, in the nutshell, discussion of what we're doing. We also have 2 grants that we've already put on the table to go forward with to support our work, and try to receive some funding that will underwrite these expenses as we go along. So, we're currently funded and currently supported by the Community Engagement Branch at MUSC, who has provided some limited support, but there's other funding mechanisms. Another item on the agenda when the new year starts is the MUSC Community Engagement Program will be providing some training so that we can work as a tight, well-greased, cohesive unit as we pursue this research agenda. So I just wanted to share that with you. I'll be around all day. I'm going to leave my cards at the table out there with Mike Graves so that you can contact me if you're from out of state and are willing to serve on this board. Did I leave anything out, Charlie? Okay. Marvin, did I leave anything out? Okay. Okay. Great. Thank you so much. Next.
Thank you. Sounds exciting. How long will it be before we hear the results of the research? Is it a 1 year, a